I'm Solène Clavreul from Myeloma Patients Europe. Apologies for the late start. We are experiencing some technical issues making our speaker access the webinar Zoom link, but we're working on this. While we wait for him, I would like to start by welcoming you to this webinar on European Hematology Association, or EHA, 2025 Myeloma Highlights, organized by Myeloma Patients Europe. I'm Solène Clavreul, a medical education and scientific engagement head at MPE, and I will be the moderator of this webinar. Next slide, please. So we will start the webinar with a short introduction and housekeeping rules, and then our speaker, Dr. Ulf-Henrik Mellqvist, will give a presentation on his highlights from the European Hematology Association 2025 Annual Conference, and then we will continue with a question and answer session before we will close the webinar at 6 p.m. Next slide, please. So first, I would like to give a short reminder on how to use the Zoom webinar app. So you can use the question and answer feature, which is found on the toolbar at the bottom of the window. And please use this feature to ask a question to the panel. Click on the like button to upvote a question and let us know what questions are of high interest to you. Don't wait until the end to ask your questions, as we will try to group them by topic while the presentation is ongoing. Use the chat feature to chat with other participants, share your experiences or comments on the current discussion, or just say hi. If you're experiencing any technical issue, please let us know about it in the chat, and one of my colleagues will assist you. Do not use the chat function to ask questions to the presenters, please, and use the Q&A feature for that purpose. We would like to inform you that this webinar is being recorded and will be available on our website, www.mpeeurope.org, and social media channels. Next slide, please. So first, I would like to present about EHA. So it's the European Hematology Association annual conference, and it's a global gathering of hematologists, researchers, clinicians, patient advocates, and industry partners. And it's a key platform for different purposes, presenting cutting-edge research and clinical findings, sharing best practices in medicine and clinical practice, advancing hematologic education through sessions, workshops, and poster presentations. So this year was the 30th edition of the Congress, and it expected more than 50,000 attendees. We also covered EHA this year. We had a team of a few MP staff members, but also coming from our member organizations coming to EHA. We have filmed some videos around key abstracts presented at EHA this year. So you can find them on our YouTube channel and watch the speakers of the conference talk about their research and results. And now we are welcoming our speaker, Dr. Ulf-Henrik Mellqvist, who will be giving his talk and his myeloma highlights from EHA 2025. Dr. Mellqvist, the floor is yours. Thank you for being here today.
Thank you very much. I'm happy to be able to talk to you all about the EHA meeting, which had a lot of interesting insights into myeloma. I would just pick up my slides. So this was the EHA meeting in Milan. And then, of course, I'm focusing on myeloma. And I will talk about first the newly diagnosed myeloma, studies about that, and move on to the relapse refractory setting. And finally, some reflections of my own from this meeting. First, a few words about MRD. This is something that is getting more and more important when you're treating patients with myeloma and also doing research in myeloma. MRD stands for, you could either say measurable residual disease or minimal residual disease. Both terms are used. And it's very sensitive methods that can discover one malignant cell within 1 million normal cells. And the reason why we are so focused on MRD today is that the prognosis in myeloma, it's so much better. So if we do clinical trials and trying to compare different treatments, it will take years until we know which one is the best. So MRD is used much more now as a surrogate marker, and hopefully our authorities will accept this as a primary endpoint in studies. So with this said, I move on to the first trial, the MIDAS trial, and this was a trial where it was where they really used this MRD concept. So patients were treated with a quadruplet with a CD38 antibody, isatuximab, a proteasome inhibitor, carfilzomib, an IMiD, lenalidomide or Revlimid, and steroids, dexamethasone. And they used this for 6 cycles in newly diagnosed patients, and then they checked MRD. If they couldn't measure any malignant cell, they said this patient is a standard risk patient, and they were randomized either to get 6 more cycles of ISA-KRD or autologous stem cell transplantation plus 2 cycles of ISA-KRD and then lenalidomide maintenance. And if you were MRD positive, you had a more intensified treatment where you received autologous stem cell transplantation once and ISA-KRD, or a tandem autologous stem cell transplantation, and followed by a much more intensive maintenance therapy with isatuximab and a new IMiD, iberdomide. What we can say about this study is that perhaps autologous stem cell transplantation added a bit more of MRD negativity when used for standard risk patients, but it's not that clear yet. And when it comes to tandem, we haven't seen a benefit, and this is something I would like to discuss with you all later. What's the role of autologous stem cell transplantation today in the treatment of multiple myeloma? Another first-line study was this MAGNETISM-6, where a bispecific antibody, elranatamab, was used. And you know, the bispecific antibodies, it's those antibodies, they are directed towards myeloma cells, but then they have another arm and grabs a defense cell, a T cell, and sort of put them together, and this is extremely effective. And in this trial, it was combined with the lenalidomide, and then it was plus or minus daratumumab, another CD38 antibody, versus daratumumab, lenalidomide, dexamethasone. And what you can say is that almost all patients that received elranatamab in any form had a very good response, and they also checked for toxicity. This was nothing that was, I think, a big problem. It was the expected side effects with neutropenia, the cytokine release syndrome. You know, when you use these treatments where you use the T cells, the immune system within the patient, it gets so activated that these messages between white blood cells, cytokines, they are sending them all over the place. And you can get fever, and if it's more complicated, you could drop in your blood pressure, you could have difficulties breathing. Usually when it's used with these bispecific. It's just you get a little fever and it's very easy to take care of. So a promising study, but early days yet. And you will see that with most of what I describe here, it's that it's either it's early with all. You could say that they respond well or they tolerate it well. Is this the best treatment? Is this the treatment that we are going to use for everybody? We seldom get those answers on the EHA meeting. Usually these results are presented at the American meetings, the ASH meeting and the ASCO meetings. So another interesting study was the ADVANCE clinical trial, where they again used KRD plus minus a CD38 antibody in newly diagnosed patients. They used this for 8 cycles, and then they added autologous stem cell transplantation only if the patient was MRD positive, and then they followed up with lenalidomide. So far, you can say that when you add daratumumab to KRD, you will see that the proportion of patients that are MRD negative, which is what we want, it increases definitely from 33 to 59%. When it comes to progression-free survival, PFS, that's the time when you have your disease under good control. It's early days. It seems that daratumumab will give a better PFS, and if we trust the MRD concept, that is what we are going to see, but it will take a longer while. Another study with this CD38 plus KRD, in this case isatuximab, that was a GMMG concept trial, where they checked this in transplant eligible patients and also in patients that were not transplant eligible. And you could see that with this quadruplet, they had a very good result when it comes to MRD negativity. And you could also see that it's sustained for a long time. And so far we could say that the median progression-free survival, it's more than 70 months, but it's also very early to say where will this end. And at the bottom right, you see for overall survival, that is how long do you survive at all, you see that that curve is very immature still, because it's so good results with a combination. Another trial with the same sort of combination, but this was then KRD plus minus CD38 antibodies, and they were trying to see what happens when you consolidate your results with adding more cycles. And you could see that the MRD rates improved, and that the MRD rates are superior when it comes to the group where they have the CD38 antibody added to it. So, and they also checked toxicity, and it didn't seem as the CD38 antibody added that much in toxicity, and that is the experience we have also in our daily clinic. Now to the treatment of relapsed refractory myeloma. The redirect clinical trial used 2 different sorts of bispecific antibodies. What's the reason for that? Well, teclistamab, that the arm that grabs the myeloma cell, that it looks for a structure on the cell surface that called BCMA. And we know that in the relapse refractory setting, some patients, they have lost this BCMA structure, or they do not express enough of it, or if they are treated with a therapy that looks for BCMA, they will hide their BCMA sort of to avoid the therapy. So then this was combined, teclistamab, looking for BCMA, was combined with another that's GPRC5D, easy name, but so sort of not to let the cells get away. And in this study, they looked in patients with extramedullary disease, and these patients, they are really high risk. Extramedullary disease, it means that these patients, they have myeloma growing somewhere in the body, not connected to the bone marrow or to any skeletal structures. And this is not a good sign, and we know that these patients really do need intensive treatment. And in this study, they showed that almost 80% of the patients, they did respond to this treatment, and they could see that this was much better when you used talquetamab or teclistamab as monotherapy, as you can see on the right hand side of this slide, where you have the combination above and the monotherapies below. So again, very promising data, and for a group of patients where we definitely have unmet medical needs. So interesting. It's not only bispecific antibodies that are produced, they now produce three specific antibodies. So this is an antibody with 3 hands. So this one antibody can grab both BCMA and GPRC5D. And again, in relapse refractory myeloma patients. And the aims of the study was, as I said, to avoid this antigen escape, that the malignant cells can hide their surface structures. And in this treatment, they had 100% response rate for patients who had never been treated with this kind of antibodies or bispecific antibodies before. So very good results. When it comes to toxicity, I would like to mention that talquetamab, the antibody that's directed to GPRC5D, this structure also exists in your skin, so you can have skin problem. But what is much more usually a much bigger problem for the patient is that it's also in your tongue, so you can lose all your ability to taste any food. And as you can see here, in this, when they used a tri-specific antibody, only 6% of the patients lost weight, but when you use only talquetamab, 30% of the patients lose a significant amount of their weight. And also when you talk to the patient, they said, I never had a treatment that I dislike as much as I do with talquetamab, even if it's effective. But in this structure, it works well. We move on to another form of T-cell directed therapy, CAR T cells. You know, the therapy where you take out defense cells from the patient, you infect these cells with a sort of empty virus, but in these viruses there are instructions for the defense cells how to kill myeloma cells. So they put that information into the defense cells of the patient. Then you have these cells at a laboratory for 2 or 3 weeks so that the cells can multiply and the patient gets their newly trained defense cells back. And this is it's standard therapy in severe cases of acute lymphatic leukemia and in lymphoma, and also in some countries for myeloma, but it's becoming more common now, also used in myeloma therapy. So in this study, Imagine-1, they tried this new CAR-T concept, and they were evaluating safety and efficacy. Again, it's so early, so you can only say that, do the patient tolerate the treatment and do they respond? And as you can see, 97% of the patients, they did respond, and there also seemed to be kind of good tolerability, that the CRS rate, you know, the cytokine release syndrome, most patients got it, but only grade 1, and that's when you get fever. You can get some steroids or another treatment called anti-IL-6, and it's gone. So we will see, and it is promising, and this is an addition to CAR T-cell therapies that already exist for multiple myeloma. CARTITUDE-1, it tests cilta-cel, and that's, I think, the most common CAR-T concept in myeloma today. And as you can see, cilta-cel is like some of the bispecifics. It's directed towards BCMA, so the T cells that the patient had got back, they can recognize BCMA. That's on the myeloma cells. And this is an follow-up where we have a more mature data. These were heavily pre-treated patients, and what we can say now is that about 1/3 of the patients still had their disease under control 5 years after they got their infusion of these trained T cells. And it's just given once. And this, we haven't seen this in relapsed refractory myeloma before. So this is very good. And you can say that with median overall survival seems also to land at about 5 years. Someone might get a bit concerned when you see no new cases of Parkinsonism. It's that CAR-T do have some neurological side effects. They are not common. We used to call them ICANS, and there are some feared side effects. For one thing, it's Parkinsonism that some patients develop. But what they could say was that you saw this neurological toxicity early on, and what they didn't know when they started the study was how would it look 5 years from now, and they could see that the side effects, they came early and then they seemed to stabilize. So also something promising for the future. This is a sort of a new bispecific linuceltamab in the linker MM2 trial, just for completion, so that I will so no one wonders why doesn't they speak about this new. And as you can see, again, very good overall response rate. That was 100% when they kept on following the patients, and after 6 months 95% of the patients remained disease-free. So, and the proportion of patients that had CRS, they were very few. So this is something new, perhaps a more tolerable bispecific antibody. So, and in this case, sorry, I didn't mention, it was also combined with carfilzomib, because we are also looking at, in the relapse refractory setting, that can you even improve the effect of these bispecific, adding some older myeloma drugs And I guess that in the relapse refractory setting, that will be the case. When these treatments move to first line, I don't know, perhaps they can stand on their own legs. There were also presented new treatment guidelines. I won't go through them in details. They are very much information, but you could say that that if you start at newly diagnosed myeloma patients, when you have seen what I've talked about in earlier studies, it's not surprising that for all patients, combinations with CD38 antibodies, a proteasome inhibitor, and IMiD, and steroids, it's recommended for all patients. You can skip some of the components. For example, if you have a patient where you're very concerned they can get neuropathy or they already have neuropathy from some other disease, you can skip the bortezomib part of it. But I'm still, if you look at the right part of the figure and you see eligibility for autologous stem cell transplantation, we stick to that. And if it's yes, we move on to autologous stem cell transplantation. Perhaps we see this for the last time in guidelines, and that it will be offered to all and not as just an option to add for some patients. When it comes to recommendations after first relapse, then this slide gets really busy. But if we start at the top, you could see that we base the recommendations on if someone is not treated with a specific drug, or if they are sensitive to a drug, or if they are refractory to a drug. So if you, for example, have treated a patient with bortezomib, they do not respond, you can check what can I give to patients who are not sensitive to bortezomib. And we have a lot of focus on patients who are refractory to lenalidomide, or perhaps both lenalidomide and bortezomib. And what you could see here is that the CAR-T has already entered the guidelines in second line. This is something new. A drug we haven't talked about is belantamab. That's an antibody that's directed to BCMA, but it's combined with a drug that in itself is quite toxic, so you can't use it directly for a myeloma patient. But combined with belantamab, this drug mafedotin can enter the myeloma cell and kill the cell from inside. This combination with Blenrep, the name of the drug, it's extremely effective. It has been even more effective than the combination with the quadruplets with daratumumab. There are some problems with toxicity and that you can get blurred vision. You can overcome that with not treating as frequently as when you start the treatment. But that's also a new kid on the block, the belantamab, also already in second line. And when we come to later relapses, you almost only see the T-cell directed therapies, CAR-T, bispecific antibodies, and of course, new clinical trials. Some of my personal reflections is that I strongly agree that CD38 antibody in first-line therapy, it's well tolerated and highly effective. It's not that effective in monotherapy, but combined with other drugs, very effective and will increase the response rate massively compared to previous treatments. And MRD negativity, still it's not the EMA, the health authorities in Europe, they have not accepted MRD as a primary endpoint in a study. But in this meeting, we heard about the Perseus trial, which is a trial where you use a quadruplet first line, and the calculated overall survival, it's more than 200 months. That's excellent, but it also gives them the problem. If you have to wait for 10 years to know is this treatment better than the other, it will slow down the development. So probably MRD negativity is something we will talk much more about, and also talk with our patients that we will follow MRD, and if you're negative, we might stop treatment, and then we just take samples for MRD, and then if you become positive, then we can start treatment again long before you have any symptoms from your disease. One bad thing about MRD still is that it's mainly based on bone marrow aspiration, but there is intensive work going on where you could check this via a blood sample instead, and then you can do it much more often. So we saw several studies with CAR-T and bispecific antibody is in the relapse setting, and we are now eager to know the results when they are used in first line. And I don't think that this will be ready within this year, but perhaps we will have some preliminary data next year about this. Also, there were some interesting symposiums where they talked about T-cell directed therapies, and a downside with those is that the patients get very sensitive towards infections, but we have learned so much more when we use these therapies that we give much more prophylactic treatment towards infections. Many patients need to have gamma globulin to prevent infections, and this is also good for patients that are not getting T-cell directed therapies. We learn much more how to deal with infections, which is one of the biggest problems for patients with myeloma. One thing that I'm a bit hesitant when studies are presented, especially those that are produced by companies. They try to measure quality of life, but it just seems to be a straight line, whatever you treat the patient with. And I'm not sure that, in my mind, if you can't taste food, if you have severe neuropathy, if you can't see that you ought to see that in quality of life. But the way we measure quality of life today, we can't see it. So I'm not sure. We have to discuss with patients' organizations, I think, how can we measure quality of life in a better way? And finally, for how long should we use autologous stem cell transplantation? It's a treatment, we are so used to giving it, we don't think about all the side effects that are connected to that treatment. Also, we know that if you undergo an autologous stem cell transplantation, you have a high risk of developing other hematological diseases. This takes many years. So this was not a problem before, when they expected the rest of the life for patients suffering from myeloma. That was not that long. Now, when we think patients will live for decades, perhaps we really have to think about, what if we do something just 4 or 5 months within their treatment that will give them a severe hematological disease 15 years later. So we have to discuss this as well. And I think that was my final slide. So now I'm happy to take the questions.
Thank you so much, Dr. Mellqvist, for this very comprehensive presentation of your most important things to know about what was presented at EHA this year. So thanks a lot. It was really helpful for us to hear from you. I would like now to move to our question and answer session. We receive few questions from our audience that we can try to answer in the remaining time we have. So the first question is around MRD. Could you tell us if it's routinely done, MRD testing, for all patients after or during treatments at the moment?
No, it's. I think the common rule is it's not used outside of clinical trials, apart from some big myeloma centers, and it's not used because we really don't have the studies that still can tell us, well, if my patients was MRD negative, now it's positive, should I start treatment, should I wait for something else? So I think that's the main reason. Also, it's a bit resource consuming, and as I said, you have to do a bone marrow aspiration, and I mean, you can take blood samples monthly. I think very few patients would like to have a bone marrow aspiration. So no, mainly in clinical trials, but it's becoming more and more common in clinical, in the daily clinical life. Yeah,
I understand. And looking at all those trials you presented that are looking at MRD or even MRD driven, do you think that is going to change in the near future, or how do you feel about this, and when do you think this is going to change?
I think it's going to change on a broad base when we have simpler ways of measuring MRD. For example, for many solid tumors, we are now looking for circulating tumor DNA. This is also done in myeloma. We have our good markers in the blood with the M protein and the free light chains and so on. So perhaps we're a bit behind there. That might give us something, but I think even more so when mass spectrometry will be used much broader. That's an extremely sensitive technique, and you use just blood. And I think if that can be used as an MRD technique, then I think that most patients will be followed for MRD.
Thank you. The second question is around the positive results that you presented from clinical trials. So patients see it as a very positive news. How long do you think it will take before patients will be able to access those new treatments that are currently under investigation?
Yes, but one thing we haven't talked about at all, it's health economy. Many of these new drugs, they are expensive. But I think that if I take my own country, Sweden, where health authorities, they have been a bit conservative, and they calculate, is it worth it? You could think that's a bit tough, but of course you have to compare for different diseases, different treatments. But we have the quadruplet with CD38 antibodies. It's allowed for all patients, because this health economy shows that it's so beneficial that it's also worth its money. Different countries, they have different systems, they have different economical possibilities, but I do believe that we will have this in all of Europe, or most parts of Europe, very soon, if you don't already have the quadruplets allowed. When it comes to bispecific and CAR T, many countries have this also. It's approved in the relapse refractory setting. not in first line because we do not have, those studies are not mature yet.
Okay, thank you. We have a question about the Imagine-1 study. So you mentioned that one person died from CRS. There were 117 patients enrolled, but one person died. And the question is, what is the repercussion of this over the trial and next steps?
Yeah, but this is why if for my personal view is that I'm not hesitant at all using bispecific antibodies. It's severe side effects. It's not more common than when you use standard treatment. CAR T is a bit different. It's a bit like allogeneic stem cell transplantation. You know, that's a treatment that actually has been allowed for myeloma since the 80s. It has never been really popular because you do have a substantial risk that something might go severely wrong in the beginning. And I think this is what we need to show in these clinical trials, that the severe side effects, they will be minimized using CAR T frontline for multiple myeloma. So I think it's a bit too early to say, but I think that if you're offered CAR T, you should be aware there are some really severe side effects that might happen. It's not probable, it's unlikely, but it might happen. And I think that's something you could discuss with the patient. Some patients, they say, well, I like what is the best, even if there are some
Risk
with that treatment. Other patients say, I'm doing quite well. I realize I have a relapse. Could you give me something that just take care of it without too much risk? So, but hopefully we will be able to say within just a few years that CAR T is safe enough. It will be very rare that something severe happens.
Thanks for your answer. Our next question is about Dara-VTD. It was not in the clinical trials you presented, but the question is about how early after starting treatment with Dara-VTD, so daratumumab, bortezomib, thalidomide, and dexamethasone. So how long does it take for the improvements in bone pain to be seen, and if the progress should be linear or if it fluctuates?
Okay, this is of course individual and depending on what kind of lesions you have from the beginning. But in my experience, after about 2 cycles, the patient is feeling that, well, something has changed, and they can see perhaps they already can lower the dose of morphine or what they have to use to relieve their skeletal the pain from their skeleton. But otherwise, I would say that if you have, for example, for a transplant eligible patient, I don't think that the maximum relief of pain is after autologous stem cell transplant. That might take 6 months or so. But I will say within 2 months. So if you haven't felt that anything has improved, you really have to think about, is this the right treatment, or am I responding in the right way?
Thank you. We have a question on the Magnetism-6 trial and about the importance of dexamethasone-free options for patients. So the combination right now is without dexamethasone. Do you think, so it's elranatamab without dexamethasone, and do you think it will likely remain dexamethasone free for patients in the future?
Yeah, I think so. We have, I think we have been using much more dexamethasone than we have needed in earlier combinations. The reason why is that when we had nothing more to offer patients that didn't respond to chemotherapy, it was shown that extremely high doses of dexamethasone could improve the situation for the patient. And then when companies did their studies, or also doctors when they did their trials, they knew that all effect from an anti-myeloma treatment got a bit better if you added dexamethasone. And we added as much as we could so that we wouldn't make the mistake that, well, the study wasn't positive because we used too little dexamethasone. But today we know that when there have been trials where we use a high dose of dexamethasone and a low dose, whatever treatment we are giving, it goes better for patients with a low dose of dexamethasone because the side effects comes mainly from the dexamethasone. And when it comes to the T-cell directed therapies, there are also some concerns that high doses of dexamethasone could hamper the effect because they could be like a wet blanket over these activated T cells. So we really would like to take the dexamethasone to as low level as possible, and preferably not use it at all in T-cell directed therapies, but also in other combinations. But still, we know that for IMiDs and proteasome inhibitors, it can enhance the effect with maybe up to 30%. So that is something that hopefully we will not give our patients that much dexamethasone as we have done, and in the T-cell directed therapies, it doesn't play any role apart from taking care of the side effects, the cytokine release syndrome. Then you would like the wet blanket to put over so that everything will calm down, but then you can take the dexamethasone away.
I understand. Thank you. We have about a question about high-risk myeloma. So how can you tailor upfront myeloma treatment for patients who have high-risk disease?
Well, some of these studies, they were into this, and I think that today my easy answer is a quadruplet with the CD38 antibodies. As for anybody else, that's the best option. But I think that what we will see is that, especially the bispecific antibodies, they will move quite quickly to first line for these really high-risk patients, because they, for the first time, we can see good result using that therapy in these high-risk patients, because that has remained a problem for us. Even when we see the prognosis is so much better for patients with myeloma, about 10 to 15% will still they have a very aggressive disease, and it's so hard for us to get it under control, and there's a big risk that the patient will have some severe infection and die from it before they have effect of their treatment. So I think that, and that will come quite soon, I guess, that we will use T-cell directed therapies in the really high-risk patients.
Thank you. We have a question on smoldering myeloma. So the question is, why do they not start treatment with smoldering myeloma? And I know there are actually some trials investigating that. So maybe you can give us a quick update on this.
Yeah, well, you could say that when we say that someone have smoldering myeloma, it's a definition, and most of you know that there is another, well, it's not a disease, it's a dyscrasia, where you have MGUS. You only have an M protein and nothing else. And then if you have more than 10% of plasma cells in your bone marrow, but everything else is okay, you would say this is a smoldering myeloma. Of course, it's not that if you have 9% it's MGUS, and if you have 10% it's asymptomatic myeloma. We know that when we look at all the patients with smoldering myeloma, 1/3 of these patients, they haven't needed any therapy for 10 years from their diagnosis of having smoldering myeloma. And that is because actually they have MCAS, because we know that the risk that they will develop treatment-demanding disease, it's very low after 10 years of observation. But at the same time, we know that about maybe up to 50%, they will need treatment within the first 5 years. And of course, it could be good starting treatment before you have your first skeletal lesion or you have impaired kidney function. And I think the studies that have been done so far, we haven't been good enough to say, well, this is really high-risk smoldering myeloma. So we need to be better with that. But already now, we do treat a lot of patients with smoldering myeloma. We know that if they have a lot of plasma cells within the bone marrow, and there are some other things, if they have a high M protein and so on, we start treatment. But we are not there yet, so that we really can say that, well, this patient needs treatment. And I don't think it's a good idea to treat all patients, because then 1/3 of them, they will never need any treatment. Even if we can take care of side effects, I wouldn't be happy if I 10 years later got someone said, well, I don't think you didn't need any treatment, but you got it anyway.
Thank you. Thanks for sharing your perspectives and knowledge around this. I would like to ask you one last question. It's about AL amyloidosis. We haven't heard any treatment updates during the talks in Milan. I know there were some posters, but maybe you could share with us what are your thoughts on the future of AL amyloidosis treatment, and what can we hope for in the future?
Yeah. I think that we do have excellent treatment for AL amyloidosis based on the CD38 antibodies, and I think that's very, very good. And the big questions for AL amyloidosis, and what we haven't solved, is if you are diagnosed and already have a lot of amyloidosis, especially in your heart, the trials where we try to clear the heart from the amyloidosis, so far we haven't seen any breakthroughs. There are studies ongoing, but no breakthroughs. Also, we are not really sure that if you have been treated for your AL amyloidosis and you are followed, and we are not really sure if we should start treatment again, on what levels of your free light chains and so on. So you could say that patients with AL amyloidosis, they will benefit from all the insights we get from multiple myeloma. And we know that bispecific antibodies will probably be an excellent treatment, or there are phase 2 trials, excellent treatment, and even CAR-T. So probably we will be able to treat AL amyloidosis even better soon as well. But me, as I am very interested in this area. I have a lot of patients with AL amyloidosis, and it's just when you realize the patient, they were walked around, nobody understood what they had for 2 years, and when you see them, they have severe heart failure, their kidneys are not functioning. I can just stop the production of amyloidosis, but I can't clear it. The patient has to clear the amyloidosis. So it's not solved. So
thank you. That was very helpful. So thank you so much for answering all those questions, for your time, for presenting your highlights from the conference. And I learned a lot, and I hope everyone will learn a lot as well. And I would like to thank you for being here with us today. And if you have any final word for our audience, please feel free to speak up, and then we will close the webinar.
Okay. Well, my final words is that, as you have heard, we have a problem that the prognosis it's so improved in myeloma. So that's a very nice problem. Still, some of you will not agree because you have a very aggressive disease. But I think that there is light in the tunnel also for you, and it's soon we will have much better treatment, or we do have them. We just need the trials to show that it should be used first line for those of you with high risk disease.
Thank you. That's very helpful. So on behalf of MPE, thank you again. And I would like to remind our audience that this webinar will be available on our YouTube channel, as well as the interviews that we have filmed at EHA with clinicians and researchers presenting their findings in key clinical trials that were also presented here by Dr. Melfist. So please have a look at those videos. They are there on our YouTube channel, and stay tuned for our next webinar on infection risk with myeloma and myeloma treatment and infection prevention that will be held in September. Have a pleasant day.
Okay, bye.
Bye.